Patients with lower risk MDS really represent the lion's share of patients that we see. And for them, the most common symptomatic cytopenia they deal with is anemia. And for patients with lower risk MDS with anemia, over time they do become transfusion dependent. And the accumulation of iron loading that can occur with them also has with that attendant complications, as you might expect. So for patients with lower risk MDS, the standard of treatment to start with is erythroid stimulating agents, or recombinant erythropoietin. It has effectiveness, but in patients that are red cell transfusion dependent, it's a very lower response rate and a very short duration of response. So where there really is a need for those patients that are transfusion dependent specifically for some new therapies that are very effective. One of those is luspatercept that we've been studying. So luspatercept is an erythroid maturation agent. It is essentially a soluble receptor for activin 2A, and then it's a chimera hooked onto an IgG1 heavy chain for circulation. But it acts as a ligand trap, primarily for the TGF-beta superfamily ligands. And as a consequence for that, by suppressing those ligands, it'll inhibit SMAD2/3 signaling, thereby allowing erythroid maturation. So this began in a Phase I/II study in Europe, and in fact in that study there was a higher response rate, transfusion independence rate in patients that had MDS with ring sideroblasts. And that was the rationale to take this forward into a Phase III study. So in this study, it was called the MEDALIST trial. So it was a randomized, double-blind, placebo-controlled trial involving 229 patients. Patients that were eligible had lower risk MDS defined by the IPSS revised criteria of very low, low, and the intermediate risk disease. Morphologically, they had to have MDS with ring sideroblasts, and that could be defined by 15% or greater ring sideroblasts in the bone marrow, or 5% or more with an SF3B1 gene mutation. They also had to be transfusion dependent, defined by receiving at least 2 units or more every 8 weeks in the 16 weeks prior to randomization. And patients that were excluded from this were patients that had previously received immunomodulatory drugs like lenalidomide or ATAs and nucleosides. Those patients, as I mentioned, were randomized in a 2-to-1 fashion to receive either luspatercept beginning at a dose of 1 milligram per kilogram as a subcutaneous injection every 3 weeks, or placebo. And the dose could be escalated all the way up to 1.75 milligrams per kilogram. And the overall response assessment occurred after week 24, and patients were reassessed every six months thereafter. Primary endpoint for the study was red blood cell transfusion independence, defined by a period of 8 weeks or longer without receiving transfusions. But there were several other key secondary endpoints, responses that occurred, transfusion independence that occurred greater than 12 weeks, and also importantly, those that had a major reduction in transfusion, what we call erythroid hematologic improvement. And that was defined by at least a 4-unit or greater reduction in red cell transfusion needs over 8 weeks in people that were heavily transfused, and in people with a lower transfusion burden, they had to have at least a 1.5 gram or greater rise in hemoglobin over 8 weeks. The primary endpoint of transfusion independence was achieved in 37.9% of patients on the luspatercept arm and in 11% of patients on the placebo arm. It was very durable. When you look at the duration of transfusion independence, there was 40% of patients that were still transfusion-free after 1 year of therapy. The median rise in hemoglobin in those patients was 2.55 grams, reaching as high as a max of 4.1 grams per deciliter in those responders. The other key secondary endpoint is, remember, these are generally heavily transfused patients, and a hematologic improvement, as I defined earlier, was achieved in 58% of patients on the luspatercept arm. So the vast majority of patients had clinical benefit, whether it's from transfusion reduction or transfusion dependence and rise in hemoglobin. This was an extremely well-tolerated drug. There was absolutely no difference in the treatment emergent adverse events in placebo compared to luspatercept, and no difference in the frequency of evolution to AML as well. Well, I think clearly it looks like it's a very effective agent, particularly in these patients that are MDS with ring sideroblasts with lower risk that are transfusion dependent. It gives us another tool in our armamentarium for patients that right now have limited treatment options.